Hello, everyone. Thank you for joining today's webinar. We are so grateful to have your time and attention for the next hour as we dive into understanding peripheral neuropathy associated with kidney disease. Here at the Foundation for Peripheral Neuropathy, we're dedicated to improving the lives of those with PN, and we're grateful for our partners like Anodyne Therapy who share our vision. Thank you to Anodyne for sponsoring today's webinar. Hi, everyone. My name is April Hubert, and I'm proud to serve as webinar moderator and director of development here at the Foundation. Thank you for tuning in today and allowing our organization to be the premier resource for information, research, and advocacy surrounding the individual and collective experience with PN. Before we begin today, I have 3 reminders for you. 1, yes, this session is being recorded. It will be emailed to you after the program and posted on our website in the coming days. The slide deck will also be available. 2, for those participating in the live session today, we will have a Q&A towards the end of our time together. Please be sure to use the questions box to submit your question, and we will try to get as many as we can answered. Please submit questions related to today's topic and refrain from sharing any personal medical information. And 3, if you are having audio issues, you can dial in by phone using the instructions that were sent to your email. Remember, this session is being recorded and you can always view it at a later date as well. Now, I am pleased to introduce our guest speaker. Dr. Ruchika Batwara is a nephrologist or a kidney care or disease doctor who graduated from All India Institute of Medical Sciences in New Delhi, India in 2003. She completed her residency in internal medicine at the Medical College of Wisconsin in 2007 and her nephrology fellowship at New York University in 2010. She's practiced in New Jersey as a nephrologist for 6 years prior to joining the nephrology division at Mount Sinai, Morningside, and West Hospitals in 2019 as an assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. As a clinician educator, she is actively engaged in quality improvement initiatives and teaching activities for fellows and house staff. She is the quality champion for the Division of Nephrology at Morningside West Campus and serves as the medical director of the inpatient dialysis unit at Mount Sinai West, as well as ACC 6 multi-specialty practice at Mount Sinai Morningside. We're so grateful to have you today. Please give a warm welcome to Dr. Batwara. We're so grateful, and the virtual floor is now yours.
Thank you so much for the kind introduction, April. That was very nice of you. Welcome, everybody. I'm honored and pleased to be here with you today and try to explain peripheral neuropathy in chronic kidney disease. I would be happy to take any questions towards the end. Next slide. So today we will be gaining some basic understanding of chronic kidney disease, talk about signs and symptoms of neuropathy in chronic kidney disease and management of peripheral neuropathy in CKD, which is essentially chronic kidney disease. And towards the end, talk about what medications are appropriate and inappropriate in chronic kidney disease. Once again, before I start, I want to just say that when we say chronic kidney disease, it's not a disease. It's just an impairment in kidney function. Next slide. So let's start with patient case. So this is usually what I present when I'm presenting to my colleagues. And I will start with this case here and make it simple for understanding. A 64-year-old man with a 15-year history of poorly controlled diabetes and a 10-year history of high blood pressure had many diabetes-related complications within the last 5 years. He experienced a fairly rapid decrease in his kidney function, noted first 2 years ago. And 4 years ago, he noted symptoms of peripheral neuropathy, seen as shooting pain and numbness with loss of light touch, change in vibratory sensation, change in heat sensation in a stocking distribution. Last year, he developed a non-healing ulcer in his left foot that was further complicated by gangrene and resulted, unfortunately, in a below-knee amputation of the left leg 1 year ago. He now reports new onset of weakness, lightheadedness, and dizziness on standing that affects his daily activities. He also reports lancinating pain in his right upper extremity, right lower extremity that is worse in the evening. Medications are those given for diabetes and high blood pressure. On exam, he has loss of sensation in to his knee and below in the remaining limb, and up to the wrists in both upper extremities. And the last part, which I'm going to explain in further detail later on, but his lab evaluations show that he has some advanced kidney disease or severe impairment in his kidney function, with an estimated glomerular filtration rate of 24%. His A1C is slightly uncontrolled at 7.9%, and he has protein in his urine. Next slide, please. The second case is a 48-year-old man with end-stage kidney disease who presented with severe decreased sensation in his feet, both feet, that started at the bottom of his feet and then gradually advanced to above ankle level over the course of 2 to 3 years. He reports the sensation of walking on cushions, as well as progressive difficulty with walking. Additionally, he also complained of ongoing pain in both legs and a change in sensation in both hands. He had been diagnosed with end-stage kidney disease at the age of 37 and has been on dialysis for the last 11 years. So these are very common scenarios that we see in our practice usually. And let's see, next slide, please. Let's start with a basic understanding of what the kidneys do and how kidney function is measured, and the whole significance of chronic kidney disease. So what do the kidneys do? We all know that kidneys are responsible for filtration and clearance of toxins from our body. That's a very simple way of putting it. But additionally, other than removing those toxins from the body, the kidneys also regulate the body's fluid balance. With fluid imbalance, people see swelling in their legs and sometimes fluid in their lungs, which can cause shortness of breath. The kidneys also regulate blood pressure via hormones. They control red blood cell production, which means if the kidneys are not working properly, people can develop anemia. They also are responsible for bone health by producing the active form of vitamin D, which is important for maintaining bones in good shape. A fun fact is that your kidneys filter about 200 liters of blood every day. They're working constantly. Our body doesn't have 200 liters, but it's like the constant circulation. And during this process, your kidneys remove waste, which leaves your body as urine, which is pee. And most people pee about 1 to 2 liters per day, and the rest, 198 liters is then recirculated in the blood. Next slide, please. So this on the left is the urinary tract, a simple version of it, where the kidneys are doing this filtration process, and the urine or the pee then goes through the ureter and comes and gets accumulated in the bladder, and eventually we pee it out. On the right side, we see a cross section of the kidney, which is a more detailed version of the kidney, where the unfiltered blood is going in. And this is where the magic is happening, the filtration, and the filtered blood then goes out and then gets pumped through the heart again. This is a more detailed version of the functional unit of the kidney, which is called a nephron. And glomerulus is a term that you might want to remember because kidney function is measured as glomerular filtration rate, but this is the functioning filtration unit of the kidney. Next slide, please. So how do we measure kidney function? As I mentioned in the last slide, kidney function capacity is measured as GFR, or glomerular filtration rate. Your doctor will tell you what your GFR is based on a blood test that we do, which measures creatinine. It's a complicated equation, which I will show on the next slide. Nobody needs to remember that, including me, but it also takes into account certain variables like age and sex. Race is no longer a variable to kind of we eliminated race in this equation recently to kind of bring some racial equity in medicine, and race was kind of harming a certain subset of our patients. So other than the blood test that measures creatinine, we also measure urine test for protein. Protein leaking from the kidney is a bad sign and suggestive of kidney disease. Again, this is to reiterate, this protein is not the same protein that we ingest. This is not the protein in our diet. So there is no reason to restrict protein in the diet in initial stages of kidney disease. But this is a different kind of protein that is leaking from the kidney when patients have kidney disease. And a measure of that will give us an idea of how bad the kidney function is. A kidney ultrasound is usually done to detect any anatomic defects as well. So these are the usual tests that your doctor will do to determine the kidney function. Next slide. This is just, for fun sake, you see this equation. I'm sure 99.9% of us do not understand this, including me. But this is a computerized equation that is used to calculate GFR, or glomerular filtration rate, or kidney function. Next slide. So this is an important slide where, if the GFR is more than 90, that's like the high normal or normal range. 60 to 90 is early stage of kidney disease, but we generally say this is something we're not worried about. The orange and the red regions are where we start getting worried about kidney impairment or kidney disease. And 15 to 60 is a broad range, but that's stage 3. So this is kind of the beginning or the moderate kidney disease stage, 30 to 60 GFR. And when the GFR goes less than 15, then it's really worrisome. That's what we call advanced kidney disease. And somewhere along the end of this red region, people have to start dialysis. This is kidney failure, and people need dialysis for survival. Next slide. This is a complicated slide, but again, just showing that we take into account the GFR, or the kidney function, if it's normal versus decrease in kidney function to less than 15%, and the protein in the urine, which is normal and increasing in severity. And as you can see, that the darker the region, the higher the chance of kidney failure and going on dialysis. So it depends on both the GFR, which is based on the blood test, and the urine test albumin or protein level. Next slide. So, we talked about kidney disease, the severity, and, it makes people very anxious to think about dialysis, and it's worrisome for a lot of people. So I just want to start by saying that more than 1 in 7 people in the United States have some degree of kidney disease. It's pretty common, 15%, and that's 37 million people. And out of those, very, very few, almost 800,000 a year, start dialysis. Now, that sounds like a big number, but out of 37 million, that's not a whole lot. So many of us live with kidney disease, some of us with advanced kidney disease, but without ever going on dialysis. Next slide, please. And interestingly, there are only 10,000 nephrologists or kidney doctors in the US. So that works out to be 3,700 chronic kidney disease patients per kidney doctor, which is a very high number. So a lot of us are not seeing kidney doctors, but are being managed by our primary care physicians or providers. And it takes a village to care for the CKD community. Next slide. When it comes to the prevalence, or how common kidney disease is, you can see in this graph that the incidence or the prevalence of kidney disease is actually increasing through the years, and it is becoming an epidemic. It is more or less related to the diabetes epidemic and the obesity epidemic, an overall change in lifestyle, but kidney disease is increasing in our country as well as everywhere else in the world. Next slide. Interestingly, when we talk about adults with kidney disease who are actually aware that they have any kidney impairment, sadly, when it, in stage 5 or advanced kidney disease, the red region that I showed, 86% of patients are aware because they are having symptoms at that stage. When it comes to stage 4 and stage 3, which is the orange region, you can see stage 4, almost 2/3 are aware that they have some kidney impairment. But stage 3, just 16%, which is very interesting and very sad actually, that people are not even aware that they have some degree of kidney impairment. And why is that? Why is this awareness so low? Next slide. That's because when it comes to the symptoms of kidney disease, many people living with CKD do not have any symptoms until they develop advanced stage or complications. And even if they have symptoms in early stage, they are kind of mundane, very routine symptoms, like they may be peeing more often or less than usual. They may have foamy urine, itchy skin, feeling tired, nausea, loss of appetite, and some weight loss. These are kind of very routine symptoms, not necessarily making people think of kidney problems. When people have advanced stage of kidney disease, these symptoms become more severe, something like trouble concentrating or change in mental status, numbness or swelling in arms and legs, achy muscles, severe cramping, shortness of breath, vomiting, trouble sleeping, and sometimes bad breath. So in general, the symptoms of kidney disease are, unlike those of heart disease or liver disease where people have severe symptoms, this is not something that people sometimes pay attention to and they may get missed. Next slide. So what causes kidney disease? The most common cause is diabetes. And other than that, high blood pressure, heart disease or heart failure, obesity, advanced age. Again, like everything else in our body, aging, our kidneys also age. So when people age, they may see impairment in their kidney function. Smoking and use of tobacco products may also cause some kidney impairment. These are the common causes. Some of the uncommon causes include glomerular disease. I won't get into the details, but also inherited conditions like polycystic kidney disease, autoimmune conditions like lupus or SLE, and severe infections causing sepsis may also cause severe kidney disease. Next slide. So when it comes to understanding the causes, as you can see here, the biggest chunk is actually diabetes. And that's important from a neuropathy standpoint as well, because diabetics also have a high risk of developing neuropathy in general without even having chronic kidney disease. So having CKD and diabetes, that's double the risk. That's a higher risk of developing neuropathy than the general patient. Next slide. So who needs screening for kidney disease? Now, I may have scared you with all these, things about kidney disease that, people, even common symptoms may indicate kidney disease. But so far, there is actually insufficient evidence to support that everybody should get a blood test done every few months to get checked for kidney function. In general, the high risk population that actually are susceptible to kidney disease because of their underlying conditions, they should definitely get screening, and those include diabetics, people with high blood pressure, obesity, age greater than 60, a family history of kidney disease, and the last one is genetic, which is APOL1 gene, which is seen in African Americans. So in general, we do not say that everybody should get blood tests done every time you see the doctor. But if you have any of these risk factors, you should definitely get screened at least yearly for kidney function. Next slide. So now shifting gears to the nervous system. We talked about the kidneys and the urinary system, and now we're going to talk a little bit about the nervous system and then integrate the two. So the nervous system consists of a central nervous system and a peripheral nervous system. This is a very simplistic approach, but the brain and spinal cord essentially constitute the central nervous system. And from there, peripheral nerves or nerves carry signals back and forth from all organs and extremities and other parts of our body back and forth to the brain, and that is your peripheral nervous system. The neural cells or the neuron are what make up this peripheral nervous system, and this is kind of what the neuron looks like. There's this cell body and there's this long axon, what we say. And then there are dendrites, or they are kind of spread out everywhere to get sensations and from all kind of every periphery possible. Okay, next slide. So what is peripheral neuropathies? Again, peripheral neuropathy is also very, very common. It affects about 30 million people in the United States, and it's not one single disease. It can affect one nerve, which is called mononeuropathy, something like carpal tunnel syndrome, or it can sometimes affect facial nerve and cause Bell's palsy, or it can affect many nerves in different distributions. If it affects people or patients in a very symmetrical distribution, something like this, it is called polyneuropathy. Or if it affects patients in a very asymmetrical kind of distribution where different nerves are affected differentially, then it's called mononeuropathy multiplex. Next slide. So what are the common causes of peripheral neuropathy? Again, we have been mentioning diabetes, and that's one of the commonest cause of peripheral neuropathy and chronic kidney disease, and that's a big subset of patients that develop peripheral neuropathy. Alcohol use, extensive alcohol use, puts people at risk for peripheral neuropathy from deficiencies in vitamins and minerals, and alcohol itself can damage the nerves. Chemotherapeutic drugs or chemotherapy for cancer, autoimmune diseases, as mentioned before, something like SLE or lupus, which you might have heard of, infections like COVID-19, HIV or AIDS, and herpes zoster or shingles. Vitamin deficiencies, mostly vitamin B complex and B12, thiamine, folic acid, and toxins. Now, toxins are a big subset of this, and that's where your kidneys come in when we talk about toxin-associated peripheral neuropathy. Next slide. So before going on to peripheral neuropathy, let's talk about what happens with our neurosystem and chronic kidney disease. In chronic kidney disease can affect not just the peripheral nervous system, but can also affect the central nervous system, that is the brain and the spinal cord. There is something called acute encephalopathy, again, a big term, but all it indicates is that people get confused and they don't remember things, forgetfulness, lack of concentration. That's what can happen in advanced kidney disease. People have poor vasculature or poor blood vessels supplying blood to the brain, and that can cause high risk of stroke, basically, in kidney disease patients. Dementia can also occur faster than a general population in kidney disease. Again, with high blood pressure, there is a risk of PRES syndrome, which is basically very high blood pressure damaging the brain. And something which is very specific to dialysis patients, people can get dialysis disequilibrium. When it comes to the peripheral nervous system, what can happen is people can get neuropathy, peripheral neuropathy, which could be sensory, and it could affect your muscles, which is called myopathy. What are the mechanisms? I'm going to talk about it a little bit in detail in the next slide. Next slide. So again, showing the same thing in a different picture. Kidney disease can cause cognitive dysfunction. It puts people at high risk for stroke, can cause autonomic neuropathy, which is affecting how the blood pressure is regulated, how our sweating and our other autonomic system is regulated, basically affecting the heart, in other words. People can get carpal tunnel syndrome. It can cause weak muscles, which is called myopathy, and peripheral neuropathy. Next slide. So this slide is titled uremic neuropathy. Uremic essentially is a term that is used for patients, is kind of the same term as chronic kidney disease. Uremia is a term that is used for when toxins accumulate in the body from kidney dysfunction. So uremic essentially means kidney disease associated neuropathy. So uremic neuropathy is kind of characteristic. What does it seem like? It is usually distal, which means it affects the peripheries. It is symmetric. It is not just one hand or one foot. It is mostly either both hands, both feet. It is kind of symmetric in the body. And it's mixed sensory motor, which means it can affect sensations, hot, cold, pain, painful to touch, those kind of symptoms. And it can cause muscle weakness. So it's both sensory and motor polyneuropathy. What happens is there is a demyelination of the neurons. Remember this neuron picture and this long axon? The sheath surrounding it is called myelin. And in chronic kidney disease, that sheath is destroyed. And that sheath is essentially responsible for nerve conduction or conduction of signals from one end to the other. So what happens is essentially degeneration of this cell, which also destroys this myelin sheath and causes disruption in conduction of these signals. It is most often severe in the distal and longer axons. What it means is that the longer this axon, the higher the risk, which essentially means affecting more the peripheries, the feet and the hands. There is relative sparing of smaller efferent neurons, which means, you won't find these symptoms in the trunk or in the upper arms, but mostly in the extremities. And it typically affects the lower extremities, which is legs, more than the hands. And sensory symptoms precede the muscle symptoms usually. And it progresses to a stocking, what we call a stocking distribution of neuropathy, as we wear stockings, the same distribution. And it causes wasting of distal leg muscles, which means the leg muscles become kind of, they kind of waste. Next slide. So how common is this uremic neuropathy? Among patients on dialysis, almost 60 to 100%, just think about it, almost 100% of patients have electrophysiologic signs of impaired nerve function. That's electrophysiologic signs. It doesn't mean that everybody is feeling it. A lower percentage of patients are actually symptomatic, but when they tested patients, 60 to 100% of them had some signs of impaired nerve function. When it comes to chronic kidney disease patients who are not on dialysis but who have advanced kidney disease, and this was a study done in 100 patients between 18 and 75 years of age with serum creatinine, the blood number that we check for kidneys, which was greater than 2, which is essentially suggests advanced kidney disease. And based on neurological symptom score and nerve conduction studies, they found that 30% had no neuropathy and 70% had some signs of neuropathy. Out of those, 6% were asymptomatic. They did not know, they had no symptoms. 51% had some symptoms, but they were non-disabling. And 13% had very severe disabling symptoms. So this slide tells you how common a neuropathy is in patients with kidney disease, especially those on dialysis. Next slide. So what are the symptoms? Again, we went briefly in the first slide, but there are common symptoms of peripheral neuropathy that you might be aware of. Ulcerations or slow healing wound, shooting pain, sensitivity to touch, lack of sensation. Then people can have trouble, difficulty walking, tingly or numb feet. And this is sometimes what happens to the dialysis patients. They kind of lose muscle mass in their hands. And as you can see here, the muscle under the thumb is kind of very wasted, and that causes weakness, essentially. This is what we call atrophied muscle in this cartoon. Next slide. So again, going over the symptoms, in uremic patients, people can have cramps, muscle twitches or increased pain sensation in feet and legs. Dialysis patients, we very often see this when they are on dialysis, severe cramps. Pain, numbness, and tingling in the feet and legs, a feeling of pins and needles sensation, a paradoxical heat sensation. Heat is not hot and cold is not cold. Restless leg syndrome, again, common in dialysis patients where people just feel the urge to move their legs all the time. That causes severe sleeping difficulties. Imbalance and muscle weakness or reduced sensation may occur. Next slide. So the causes of uremic neuropathy. Unfortunately, even though medicine is very advanced, there is a lot of unknown in medicine, and this is one of those where the exact cause is not known. The possible etiologies based on animal and human studies include accumulation of middle molecules. Now, let me just tell you what middle molecules are. They are nothing but some of those toxins that dialysis, that patients with advanced kidney disease accumulate in their body. And those include include phenols, myoinositol, and beta-2 microglobulin. So these are essentially what we call uremic toxins that accumulate because the kidneys are not able to eliminate them. And a lot of these, unfortunately, even though dialysis is supposed to treat kidney failure and kind of get rid of all the toxins that are accumulating in the body because of kidney failure, it's not the same as the original kidney. So there are still toxins that are not removed by dialysis that would be removed by native kidneys or human kidneys. So it's not 100% effective in clearing toxins. So we see this more often in patients who are on dialysis, that these middle molecules or uremic toxins develop sometimes. Deficiencies of vitamins are very common in kidney disease patients, especially thiamine, zinc, and biotin, and zinc is removed with dialysis, so there is higher risk of deficiency. Decreased transketolase activity, which is important for nerve health. Hyperparathyroidism, high phosphorus levels in the blood. Again, these are big terms, but essentially indicate hormone imbalance and high levels of phosphate in the blood because of kidney failure. And hyperkalemia is essentially high potassium in the blood, which can also happen in advanced kidney disease and in dialysis, and that kind of changes how the membranes are, how the nerve conduction occurs. Next slide. So how do you diagnose peripheral neuropathy? In general, peripheral neuropathy diagnosis is made by physical examination, blood tests, imaging studies like MRI, and sometimes people need a skin biopsy and an EMG or an electromyography. When it comes specifically to uremic neuropathy, next slide. The diagnosis is a diagnosis of exclusion. So essentially what it means is that you still have to exclude the other reasons that neuropathy can occur in patients. So it's called the diagnosis of exclusion, and it involves complete exam of the neurological system by the doctor, imaging tests like CAT scan or MRI of the brain if there is a suspicion of stroke, which is again not uncommon in dialysis and advanced CKD, and if there is a suspicion for tumor, then you would need imaging. Labs are essential, like we discussed. Vitamin and mineral deficiencies can cause neuropathy, so those need to be checked. Vitamin B12, folic acid levels, thyroid, liver, kidney function all need to be checked because you need to eliminate other causes like thyroid and liver causing any neuropathy. And then evaluation for autoimmune vasculitis or autoimmune disease, rule out diabetes by glucose tolerance test, test for certain antibodies, test for Lyme disease, HIV, etc. So it's a whole slew of tests that you need. And then once you rule out everything, nerve conduction studies are the gold standard for the diagnosis of uremic neuropathy. So what nerve conduction studies demonstrate is essentially like what we discussed in the last few slides. There is a reduced sensory amplitude. So there is a delay in the nerve conduction from one part of the body to the other, and it's mostly tested in the leg nerves here. Sural nerve, which is in the leg, is the most sensitive indicator of uremic neuropathy, but what we most commonly use is a peroneal nerve. Essentially, your doctor needs to do nerve conduction studies to kind of determine that there is a definite conduction delay, and this is neuropathy. And once other causes are eliminated, we call it uremic neuropathy. Like I showed in the previous slide, there is no way to measure those middle molecules or toxins. Those are just, those are experimental numbers that we know, we have measured in animals, but we do not routinely measure those to say that there is high degree of uremic toxins in the body and that's causing it. So we cannot measure that, but this is how we kind of diagnose chronic kidney disease or uremic neuropathy. Next slide. So what is the treatment? Again, uremic neuropathy occurs in patients with advanced kidney disease. If you remember that picture, the ones in the red region are the one at risk. Kidney function less than 15%. Those are the ones at risk. And that is an indication. If a patient develops polyneuropathy, that is an indication that they need to either start dialysis or we have to consider transplantation seriously. Among those who are already on dialysis and developing these symptoms, then the dialysis prescription needs to be assessed. Not everybody gets the same dose of dialysis. Not everybody gets the same time, and how we run the blood through the machine, the dialysis machine. So the nephrologist or the kidney doctor needs to look at the delivered dose of dialysis and maybe increase it to see if that improves the symptoms. Unfortunately, despite increasing the dialysis dose, the reversibility is sometimes questionable. And the improvement depends on how severe the clinical symptoms were prior to even starting dialysis. So complete resolution may occur in patients who have mild symptoms, but those who have severe symptoms, they may still have residual symptoms even after increasing the dose of dialysis or even starting dialysis in patients who are not on it. And these symptoms may persist many, many years, after starting dialysis. If a patient is a suitable candidate for transplantation and is on the transplant list, then they need to be strongly encouraged to pursue that, because transplantation may reverse the symptoms of neuropathy, even when dialysis fails. So according to a current opinion, transplantation is the best treatment for neuropathy, but unfortunately we don't have enough kidneys to give everybody with kidney disease a kidney transplant. So, but that should be encouraged to kind of pursue that avenue if possible. According to current opinion, just checking nerve conduction studies routinely has no role, because clinical manifestations do not always correlate with those, nerve studies. Any improvement in symptoms may not correlate with the nerve conduction study. Next slide. Other than dialysis and transplantation, the routine usual modalities for any neuropathy patient is also applicable here. Topical anesthetics like capsaicin cream or lidocaine patches. Vitamin and other deficiencies need to be corrected. Yoga, relaxation techniques, physical therapy is useful. TENS or transcutaneous electrical nerve stimulation may be useful. And acupuncture. I'm not a specialist of that, but that improves symptoms in a lot of patients sometimes. Next slide. If all fails, we got to treat the pain. And this is where we run into problem with patients who have advanced kidney disease and who have neuropathic pain. Gabapentin or Lyrica or pregabalin are the most commonly used medications that should be the first line for treating neuropathic pain in patients with kidney disease. And if those are ineffective, we use antidepressants like amitriptyline, carbamazepine. If even those are ineffective, then we go down the route of pain treatment, generalized analgesic treatment. Next slide. So the WHO has a stepwise analgesic ladder for patients with kidney disease. This is extremely important to know and remember for anybody who has kidney disease, because we tend to use pain medication sometimes without knowing the effect on the body. And I would say if there is one take-home thing here, it would be this, that NSAIDs are the ones that we commonly buy over the counter, Advil, Aleve, Motrin, ibuprofen, Excedrin, not to be used in patients with kidney disease. They can affect your kidneys very badly. Tylenol or paracetamol or acetaminophen are okay. If acetaminophen fails, then the next step is tramadol or hydrocodone or oxycodone, which are essentially narcotics, but pain needs to be treated. It needs to be treated. And if that also fails, then we go to the bigger guns, which is Dilaudid or fentanyl or methadone. Again, this is stepwise, and generally speaking, if all else fails. We do not necessarily encourage starting here, but if everything else that we discussed in previous slides fails and the pain is severe and uncontrolled, we got to get here. Next slide. This is something that, again, I don't want to go into the details here, but in patients with chronic kidney disease, there are some general principles of pain management, which your doctor should tell you. Oral medications are preferred. Dialysis patients have IV access during dialysis, but we prefer oral medications to IV. Generally, post-dialysis is when they should be given because they are removed with dialysis. by the ladder, which means stepwise. We do not jump one step and go to the other, to the higher step. We want to try the gentler or the more safer medications first. They should be tailored for the individual. Every patient is different. Every patient experiencing pain is different, and pain should be tailored. Pain management should be tailored to the individual. And there should be attention to detail, which means that, there are medications that are not recommended for patients with advanced kidney disease because they can damage the kidneys, or they tend to accumulate because the kidneys are not eliminating those medications. So it should be a very careful selection of medications. And sometimes, in these studies that are done for pain management, chronic kidney disease patients, unfortunately, are excluded because of this reason, that pain medications are not easily eliminated in those patients because their kidneys are not working very well. Next slide. Again, a very busy slide, something we're not going to go in detail, but I just want to, again, as I mentioned in the previous slide, every medication is different. What is excreted in the urine, their half-life, and their metabolites. Some of these medications get metabolized into substances that are also accumulating in patients with kidney disease, and they can cause problems. Not all of these medicines are dialysable. Sometimes they just accumulate. For example, codeine, and that's why it's not recommended in patients on dialysis, because the patients are not going to eliminate them, and they can cause low blood pressure and respiratory depression, or basically the breathing can fail. And again, going to the last drug here, gabapentin, they're dose dependent on GFR, which if your doctor is not aware, they should be aware, but if they are not paying attention, then this is something to bring up. So if somebody has kidney disease, then they should be very careful with the kind of pain medication they're being treated with. Always ask your doctor if this is safe in kidney disease, and if the dose being given is appropriate for kidney disease. Same with dialysis patients. Just ask if this medication would be affected because of dialysis. Is this medication going to be removed with dialysis? Should I just be taking it after dialysis? And if it is getting metabolized into substances that are not being dialyzed, is it going to affect, cause side effects? That's also important to understand. Next slide. So why do we need to pay attention to uremic neuropathy? I mean, it's obvious that pain is very, very important to treat. Absolutely. Other than that, uremic neuropathy can also cause poor exercise tolerance, which leads to a poor lifestyle, and no exercise adds on to weight gain, obesity, and other lifestyle issues. People can have reduced functional capacity. They're not able to do their daily activities or work that they are used to doing. Falls and fractures, very important, and at advanced ages, in older people, these can be very detrimental. One study has reported an association between peripheral neuropathy and walking speed with the quality of life in patients with chronic kidney disease. Of course, quality of life is being affected. And overall increased morbidity and mortality. People can die, again, not to cause undue anxiety, but the first patient that we saw, that was a very sad case where the patient lost a limb, and that's very sad. All right, next slide. So the first patient follow-up, what should be done or what would have been done? That patient was a diabetic, if you remember. He had those two things going together, kidney disease and diabetes. So managing diabetes is critical in that patient. He should have been started on gabapentin for pain control with close monitoring and dose titration up based on his kidney function. Next step would have been an antidepressant, duloxetine, to kind of, again, titrate it up to what works for the patient. If that fails, and if the non-pharmacological or non-medicinal therapies that we have discussed, those also fail, then the next step is addition of opioid. Remember, no NSAIDs, no Advil, Aleve, Motrin, ibuprofen, Excedrin in these patients. The second patient who was on dialysis the doctor should have increased the dialysis frequency or time to give more dialysis and try to remove more of those middle molecules and uremic toxins. Transplant evaluation is critical if the patient is a candidate. Then again, the same medicines for symptom control based on dialysis dose here. And of course, both these patients need foot care, which is very essential. So seeing a podiatrist, making sure the ulcerations are taken care of. We don't want the gangrene, we don't want any gangrene or infection or any progression of that, which eventually can unfortunately cause a foot amputation as well. All right, next slide. So take home messages. Peripheral neuropathy is very, very common in advanced CKD and dialysis patients, especially those in diabetics. It's a diagnosis of exclusion, and nerve conduction studies may be needed once we do all the lab and other tests. The exact cause, what is causing this, is unclear, but it is likely due to accumulation of uremic toxins. The treatment in dialysis patients is increasing the dialysis dose, or in those who are eligible, and especially those who have a living donor, they should be going for a kidney transplantation. Along with medication, careful selection of medications for pain control and non-pharmacological treatments. Caution with pain medicine selection and dose in chronic kidney disease and dialysis patients is paramount. Renal transplant is the best possible way to treat and possibly reverse uremic neuropathy. All right, next slide. Okay, I think that was the end of it.
Thank you so much, Dr. Batwara. I appreciate your time, and I hope that our audience was able to glean some helpful information from this presentation. We're going to switch gears here just for a little bit and answer some questions that have come in from the chat. So I'm going to start off with our first question here. I was asking for some additional information about the relationship between hypertension, chronic kidney disease, and peripheral neuropathy. Does one cause the other? Is there kind of an order of diagnoses? What would be your expertise here?
That's a great question. And I would start by saying that most of our patients in our chronic kidney disease clinic, they have high blood pressure. High blood pressure comes with kidney disease. Now it's a chicken and egg situation. What came first? Because kidneys are responsible for regulating blood pressure. But most patients that, if a patient has long-standing hypertension, they are at risk for developing kidney disease. So definitely, if somebody has high blood pressure, that is an indication that their kidney function should be checked every year at least, which includes blood and urine tests, both. When it comes to the relationship with neuropathy, I mean, again, hypertension, if the hypertension is uncontrolled, and by uncontrolled, I mean really bad high blood pressure, that does affect the nervous system. That can cause stroke, that can cause neuropathy. But in general, just having a diagnosis of high blood pressure, but if it's well treated, the correlation is poor, then they shouldn't be getting neuropathic symptoms just from high blood pressure.
Okay, wonderful. That's great to know. So speaking of the frequency for screenings for those who have those, who are in the high-risk populations, would there be any reason to have a screening more often than once a year?
The answer would be very nuanced, and I would say that depending on the risk factors, if somebody has multiple risk factors, somebody is a diabetic, they have high blood pressure, and any of those other factors like high body mass index, or they are older, then I would say that I would probably do it every 6 months, or sometimes they are on medications, they are on medications that can affect the kidneys, and definitely the frequency changes. The frequency I mentioned once a year is for those very stable patients who just have that diagnosis, but their conditions are well controlled. In that case, once a year is okay. But if the risk factors are higher, then they should be getting checked more often. Absolutely. Patients in our office, the frequency of checking is anywhere between 3 months to yearly. it depends on the risk factors, and that's something that the doctor should determine.
Absolutely. Yeah, it's a very individualized health journey. So we absolutely thank you for that information. Speaking of kind of prevention of these types of diseases, whether it's hypertension, chronic kidney disease, or neuropathy, do you have recommendations for specific diets or supplements or things that people can take to prevent specifically chronic kidney disease?
Excellent question, and this is something that again comes up very often. Uh, Most important thing, of course, is treating the underlying condition that is causing the kidney disease. So if somebody is a diabetic, the first thing to focus on is a diabetic diet. They need to follow a diabetic diet more than anything else. Other dietary restrictions, the most important one for kidneys is salt, 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 1, 2, and 3. Sodium is directly proportional. High sodium intake affects the kidneys badly. So the recommended diet for patients with kidney disease is a DASH diet, what we call, or which is similar to a Mediterranean diet. More vegetable and plant-based foods and protein, whole grains, eggs or white meat, and avoidance of red meat in general. You could Google a DASH diet for, that's also very good for kidney disease. But if I have to focus on one thing, that would be salt. And sometimes people ask if, how much water to drink. And, if they should be drinking more water to flush the kidneys. And that's a myth, I would say. There is nothing like flushing your kidneys. You just drink to keep yourself hydrated, which your body should tell you. If you're thirsty, you drink water. You should never go dehydrated. You should never go, stay thirsty. And, your urine output should be about a liter or at least more than a liter. But peeing 3 liters is not necessarily better than peeing 1 liter. So excessive fluid intake is not, necessarily recommended unless somebody has kidney stones. Now that's a different condition. So that's essentially and when it comes to supplement, we have to be careful. Patients with advanced kidney disease, again, the kidneys are not getting rid of a lot of things, for example, potassium. So things like coconut water, which is generally considered very good, or even avocados, considered very good for your health. But if somebody has advanced kidney disease, they're at high risk for high potassium in their blood, which could be detrimental to the heart. So depending on where somebody is on that spectrum of kidney disease, they may need to restrict certain foods which are high in potassium and certain supplements. Just over-the-counter supplements, having multivitamins sometimes have potassium and other minerals, which may not necessarily be, good for the kidney. But there are kidney-specific vitamins which are recommended. In general, some people like to, garlic or, other plant-based supplements. They're not necessarily harmful. When it comes to other supplements, just which are sold as, for kidney health or this health or that health, I don't have experience with that, or, we don't prescribe that. I would say this though, they're not FDA regulated. So if somebody is prescribing it to you, or if you're getting it, you got to go through the labels carefully, show it to your doctor, make sure it doesn't have anything that can hurt your kidneys, especially heavy metals. These supplements are not tested very well if they're not tested by the FDA. So we got to be careful about heavy metals in these supplements.
Okay, that's wonderful. And just a follow-up question here. We did have a question coming in for those folks who live in states where cannabis is legal. If you have any recommendations for THC, CBD, CBN gummies, if there's any linkage or research in between those types of treatments with kidney disease.
I should have put that in the slide. I'm sorry. That's again a very good question. And there is cannabis does not harm your kidneys in any form. So if that is something that somebody needs for pain control, absolutely. They, medical marijuana or cannabis in any form, from a kidney standpoint, there is no contraindication. So you could use that for pain control. And sometimes, patients do come in, they are taking cannabis just for pain control. Absolutely, that is not uncommonly seen in kidney patients.
Okay, wonderful. Okay, so I'm going to read a question here. This is from Catherine. She is asking, with respect to looking for antibodies to nerve components, how conclusive is this in ruling out kidney disease as the cause of PN?
So I would say this, that, kid, when we say this is from the kidney disease, so usually when somebody has peripheral neuropathy and they have, other conditions and they have advanced kidney disease, it is a multifactorial thing. It could be different things coming together. We cannot say that that only one of those is causing peripheral neuropathy and the other isn't. Somebody has advanced kidney disease and they have some autoimmune condition, let's say SLE or something, or we are trying to rule it out. The antibodies would rule out those conditions, that we are suspecting. But saying that if we rule those out, that means it is the kidney that is causing the problem. It's a diagnosis of exclusion. We got to make sure that nothing else is going on, and then we say, hey, this is probably just the kidneys. Unfortunately, like I mentioned before, there is no specific blood test or urine test we can do to test those toxins and say that, hey, this toxin is accumulating in your body and this is the one that is causing uremic neuropathy. That, unfortunately, medical science is not that advanced to test for that toxin. So it's more or less, once you rule other things out, you kind of say that this is probably from the toxins accumulating from the kidney.
Okay, understood. And speaking of diabetes, because that is such a underlying condition for many, many other condition diagnoses, can you explain maybe again, or maybe in different terms, about how high blood sugar causes nerve damage in general?
Sure. I'm not the expert of diabetes, but I will explain it to you. What happens is, with uncontrolled glucose levels, there is something called AGE, advanced glycosylation products. Basically, there are products formed in the blood, and that from the glucose that attaches to the end of certain molecules, which then becomes toxins. So it's called AGE, or advanced glycosylation end products. And those eventually kind of affect, those are the products that actually affect the kidneys, that affect the nerves, and affect other organs of the body as well. Diabetes, as we know, is something that it's not just diabetes. It can affect eyes, it can affect nerves. Those are all called end organ damage. If somebody has one of those, it's likely that they're at risk of developing the other. So if somebody has eye disease from diabetes, they're at high risk for kidney disease from diabetes and from neuropathy from diabetes. So the treatment again would be controlling the high blood sugar, and for any of these conditions, I would say that should be the first and foremost, because once the damage has occurred, there is no reversibility in the kidneys or the nerves or the eyes. So this needs to be a preventative thing more than anything.
Absolutely. Understood. Okay. Well, we're reaching the end of our time together. So thank you all for sending in your questions. We will populate our contact information here up on the screen. If we did not get to your question, please send that to us at our info box and we can try to get that answered for you. But I want to thank Dr. Batwara for volunteering your time today and expertise for our program. And thank you also to our sponsor, again, Anodyne Therapy. I'm really confident that the presentation and Q&A session allowed our participants to glean some helpful information. If anything, I met a nephrologist today and now I know what a nephrologist is. So we also love to hear from our PN community. Please take the survey at the end of this webinar. It helps us create better content for you and make sure that we are able to continue this type of content. Also, please consider making a personally significant donation to the foundation so we can continue to provide programs like this and expand our mission. We make a difference for many, many folks with a PN diagnosis, and we've got a QR code up on the screen. If you want to make a secure donation, you can just use your smartphone right there. Our contact and website information is on there for your convenience. So on behalf of the entire team here at the Foundation, we wish you health and bright days ahead. Thank you for allowing us to be a part of your peripheral neuropathy story. Have a wonderful rest of your day, and we will see you next time. Thank you, everyone.
Thank you.